the president of the ESSM. It is my pleasure to introduce to this new webinar organized by our educational committee. So if I can have the slides, it is my pleasure. This is a very hot topic on regenerative medicine related to sexual function. So I can see just Carlo view, but not the slide. Now, thank you. First of all, I'd like to thank our sponsor, RegionLab, and particularly Sam Ward, who worked on the possibility to have this webinar. For sure, I'd like to give you very few information. The first one is related that we are running the second wave of the third wave of our book. So if I can have the next slide.
We are having some technical issues, just
no problem.
Wait a few seconds.
I can do without the slides for sure. Anyway, in the meantime, we are seeing people join us. Oh, let's go in this way, Danny, if it does not work. So go ahead, number 3. That's fine. So I'd like to remind you that, as always, this webinar is going to be recorded. So it will be very soon available in our website. Next. As I said, it is my pleasure to thank again RegionLab for giving us an unrestricted grant to support this webinar based on male sexual dysfunction. We are going also to produce another webinar on mainly focused on female sexual dysfunction. The information will be available soon. As I was mentioning, I'd like to emphasize that we are running, as always, our educational activity and the ESSM School and Advanced course. So previous slide, please. And there are still some positions available. In addition, we are also launching a new educational project called EFUS, mainly related to the evaluation of female ultrasound for the management and the diagnosis of female sexual dysfunction. For both educational activity, ESSM has provided some grants, so please go to our website to get more information. As I said, there will be some new webinar. The next one will be on 21 of November and the last one of 18 of December. So the information will be available soon on our website. I'd like also to thank all the educational committee, in particular Mikkel Fod, Kobe Reisman, Evi Kirana, as well as Francesca Tripodi, since they are doing a fantastic job in updating and receiving and revising the new updating chapter of our books, and the books for sure will be available in 2004. Finally, I'd like to remind you that there is also still some time to apply for the ESSM Award of Excellent, which will be give to a young guy who provided a great work on sexual science and particular sexual medicine. So again, go to our website to apply. This is a fantastic recognition of the field. Now it is my pleasure to give the word to a friend of mine, past president of our society, Carlo Bettotti. Please, Carlo.
Thank you very much, Giovanni. I will take less than 1 minute just to thanks both you and Mikkel for the amazing job you are doing for making next ESSM annual Congress that will be in February 8 to 10 in Bari. That is the city where I live, and so I'm very proud really to host the meeting. And everything concerning scientific program, social events, and whatever would be amazing. And I hope only about the weather. I cannot be sure about that. And really, I look forward to see all of you guys next 4 months in Italy to come to Bari and enjoy the meeting. Thank you very much, Giovanni, for giving me the chance to remind about our next meeting. So I think now it's Mikkel. Mikkel, it's your turn now.
Thank you. And my message is the same. Please do join us in Bali for the next Congress. It's going to be very exciting. We're going to span the whole field of sexual medicine, as we've done in the past many years. It's going to be news, and it's going to be state-of-the-art lectures. It's going to be the best of the best within the field of sexual medicine. It's going to be really condensed, and there's going to be something for everybody. And I do think the weather is going to be excellent, and I know the food is. So please do join us. And remember these important dates on the slide here. Abstract submission closes in just a couple of days on the 19th of October. So please submit your abstracts and keep posted on that. And the Congress registration is open now. Early bird fee is open until October 31st. So register before then and do get a spot in the Congress Hotel. Look forward to seeing you in Bali.
Thank you, Mikkel. Unfortunately, Daniel, the chair of our educational committee, cannot join us due to problems at work. So as I told you, I'd like to thank Daniel for this fantastic job. Today topic is male regenerative therapy, state of the art. I'm really proud to have is one of the most worldwide experts on this field. So, and also past president of our society, Dimitris Hatzichristou will chair, will chair the webinar. Next. We have a fantastic and fascinating speaker, Sam Ward. I'd like to thank again Sam Ward for his word, and also Sebastien, Beley from France, who will cover all aspects of this topic. I'd like to remind you that you are allowed to submit some questions using QA tool. Question will be collected and discussed just after the both presentation. Again, I'm sure that you will really enjoy our webinar. So I'd like also to invite, as I told you, to the next one. And now the word is to gives to Dimitris for the introduction of the next speaker. So thank you, everybody, and enjoying the webinar.
Thank you very much, everybody, for being here in a very provocative topic. I think that everybody recognizes the two prestigious speakers we have. They have done a lot in this field for many years, both of them. And I don't want to waste time saying more words. Let's have, first of all, their talks, and I will say more about them when we have the live discussion between us. So we are ready to start with the first video by Sam.
Thank you very much, Dimitris, for your introduction. So let's just allow a few seconds so that our technician can upload the first video.
Okay. Can we ask the participants in the meantime? Oh, we are ready or not? In the meantime, how many they use PRP in their everyday clinical practice? I don't know if there's a way. Possibly they can write on the chat their experience and how they use it.
Good suggestion, Dimitris.
Welcome everyone tonight. I would like to thank European Society for Sexual Medicine to provide the opportunity tonight to talk about regenerative therapies. I would also like to thank our sponsor of this evening, RegenLab, a company that is specialized in PRP and cell therapy specialties. The continuous support of pharmaceutical companies and medical societies is crucial and enables us healthcare professionals to organize and maintain high-level education activities like these all year long. For those who don't know me, I'm Sam Ward, a Belgian urologist and urologist specialized in men's health issues and fertility. I have the privilege of working in a private clinic, La Clinique Saint-Jean, which we could translate in English by St. John's Clinic, a private hospital in the city center of Brussels, where I work with 3 amazing colleagues and a soon 4th one will come. We've welcomed in the past a year several residents from abroad for short stays from 3 to 6 months. If you want to apply, just send me an email. Some of you might know me as a social media editor of the European Society of Sexual Medicine. And while I'm presenting, I invite all of you to share some messages on your social media channels with the hashtag ESSM Webinars. You can use my Linktree QR code to find my social media channels or contact me later on if you have any questions. Since 2 years, I'm also a board member of the UNESCO Chair for Sexual Health. It's a chair, not a society, but an advocacy collective of experts who wants to promote sexual health based upon human rights. And I invite you all to surf on its website whenever you have time. These are my disclosures. Today, we know that the prevalence of erectile dysfunction has increased, especially in recent decades. We all know the data from the Massachusetts male aging study and the incidence at any given age of male sexual dysfunction. Although many treatments offer benefits for patients with male sexual dysfunction and especially erectile dysfunction, unmet therapeutic needs in men's health remain a real burden. Luckily, continuously promising new approaches are under investigation. Tonight, we'll talk about those new approaches with a focus on regenerative therapies and try to understand the rationale behind them. What are those therapies and why is there such a high demand among citizens and patients? What do we know? What different regenerative therapies exist regarding male sexual dysfunction with a focus on ED and PE? What questions remain unanswered? My esteemed French colleague, Dr. Beley, Sebastien, will dive deeper into the application of those treatments in daily outpatient clinical settings and share his own personal experience. I'm also delighted to have Professor Hatzichristou Dimitris with us as a moderator. He's a world-known urologist and has published a lot about these topics the past several years. So what's the fuss? What is a regenerative therapy? Regenerative medicine seeks to replace tissue or organs that have been damaged over time by age, disease, trauma, or congenital issues versus a more classical or current clinical strategy that focuses primarily on treating the symptoms. It's the care versus cure paradigm, or sometimes dilemma. The tools used to realize these outcomes are tissue engineering, cellular therapies, and the use of medical devices as well as artificial organs. A majority of male sexual dysfunction include disorders of penile appearance and function with insufficient erection and abnormal penile curvature. We all know that etiologies are commonly multifactorial and include continued atrophy due to diabetes mellitus as well as neurovascular injuries after prostatectomy, for instance, among many other causes. The damage to penile functioning can be irreversible as vascular and neurological changes occur. Globally, disorders of penile function and curvature are insufficiently treated with traditional therapeutic modalities that do not reverse the underlying pathology. And this is where the drive starts. We call it patient preferences. The importance of patient preferences is not at all a new concept. Several studies have been published the past decades about patient preference and how to address them in daily practice. I invite you all to read this review, which is quite interesting and highlights the main drive of patients regarding decision-making, especially related to healthcare issues. The past decades, a shift in cure and even treatment at any cost has been made towards an important level of, let's say, perceived quality of life. Treatment carry risks of adverse effects or complication, and most available treatments take the spontaneity out of sex, as intimacy needs then to be planned according to the application, use, and onset of the effects. This situation can feel unnatural to some patients and their partners, affecting thus their quality of life. Therefore, treatments are highly desirable, the real cure. Quality of life today, and especially in oncological setting, is the main drive behind patient decision-making. It should not surprise us that in that view, taking into account the majority of patients prefer a cure for their sexual dysfunctions, especially when related to sexual health. Let me share you one of the most recurrent questions in my daily practice. Thank you, doctor, for this treatment. I'm very satisfied, but will I need to take this all my life? Will I always need to have to take this tablet or wear this device, etc., etc.? Patient preference is a cure, and it's definitely one of the main drivers behind regenerative therapies. What are regenerative therapies in male sexual dysfunction? Grossly, we can identify 4 axes of regenerative therapies. Those who focus on lifestyle changes using different medical devices, low-intensity shockwave therapy, stem cells, and platelet-rich plasma. Within the next few minutes, I would like to dive deeper into the last 3 of those modalities, as lifestyle changes is something we really know for a very long time, and also for the sake of time, because it would really keep us here all night. Know that a lot of startups are developing medical devices and applications to empower our patients to make lasting changes in lifestyle, with a major impact on physical and mental health. In the end, of course, also improving sexual health. Maybe, or perhaps a quick mention of a game changer the past several months is semaglutide, which some of you might know under the name of Ozempic for diabetic patients, and commercialized under the name of Wegovy, a simple weight loss medication. More and more studies are being published on the lasting effects of this medication and benefits and a major impact of regaining activity and sexual function by restoring the function of the organ. Low-intensity shockwave therapy is a non-invasive technique that uses a target passage of acoustic waves through tissues or organs. The technology was originally introduced as a non-invasive treatment for kidney stones and has since been used in the management of many other conditions, including bone fracture, musculoskeletal disorders, cardiovascular disease, and wound healing. Despite recent promising clinical results, the underlying mechanism of action of low-intensity extracorporeal shockwave therapy for ED is mostly unclear and still under investigation. Different pathways have been suggested, and 2 reviews articles are really worthy to mention today. It's nice to share those 2 references, first of all, because of the content, but also because the first one was written by Professor Foden, a board member of the European Society for Sexual Medicine and scientific and educational chair of our society, and the second because our esteemed moderator participated in its publication. What can we learn from them? So what is the exact mechanism of action we know today? This drawing summarizes it all. The acoustic waves are hypothesized to activate cellular pathways by 4 mechanisms. First, increase the expression of local growth factors with the recruitment of immune cells. And some authors have also demonstrated that recruitment of stem cells occurs in animal models. Second, improving endothelial function. Shockwave therapy has been shown to induce immediate vasodilatation, which gives rise to the hypothesis that shockwave treatment could modulate the production of NO or other vasodilators. Third, angiogenesis. The mechanism of this observed neoangiogenesis are thought to include upregulation of growth factors such as VEGF. VEGF protein and mRNA expression were upregulated in shockwave-treated ischemic pig hearts, rat hind limb, and in a rat osteotomy model. Another mechanism by which shockwaves might induce this new blood vessel creation is the recruitment of stem cells and progenitor cells. Fourth, regeneration of nerve fibers. Very few studies have investigated the effects of shockwave therapy on nerve regeneration. Some authors suggest that shock waves ameliorate degeneration and improve removal of degenerated axons, increasing the regenerative capacity of the injured axons. Some other studies suggest an effect of shockwave therapy on nerve regeneration, which could be established by supporting the Schwann cell proliferation. Schwann cells are their phenotype from myelinated to multiplying and activated, and they form the bands of Bungner, which act as a guide for developing new axons. Therefore, they could regenerate nerve fibers. Although convincing effects have not been reported in all those studies, enthusiasm for using low-intensity shockwave therapy for ED remains high. Anyway, today, the European Association of Urology has included shockwave therapy for mild vasculogenic erectile dysfunction in the guidelines. Stem cells are undifferentiated cells that can differentiate into several cell lineages and are classified depending on their origin and potency. Sources of adult mesenchymal stem cells or bone marrow, which is truly most commonly used, adipose tissue, which is most of the time easily available, and umbilical cord blood. When a stem cell is divided, the daughter cells can either remain stem cells or differentiate into specialized cell types, for instance, muscle or nerve tissue cells. Their ability for division, differentiation, and tissue regeneration is affected by their environment, which supports the stem cells and interacts with them, affecting their transformation to dedicated cell types and promoting so their self-renewal. The regenerative effects of stem cells are attained by the secretion of numerous growth factors, paracrine action, and/or the migration of the injury site along with cell contact and cellular differentiation. In these sites, they could regenerate the damaged tissue according to the stimuli or the received signals. Stem cells have been used for the treatment of many diseases since the 90s and have shown promising potential, allowing scientists to consider their use as a plausible candidate or approach. Their importance is reflected by their wide application as their anti-inflammatory, restorative, and immunomodulatory properties are linked with the treatment of cardiovascular, neurological, autoimmune, and hematological diseases, even Parkinson's disease, stroke, spinal cord injuries. And that's why it is possible that diseases or pathological conditions of the urinary system would also benefit from the use of stem cells. Stem cells have multiple characteristics that could improve ED in patients, such as differentiation in multiple cell lines, self-regeneration, and multiplying capability. Most of the evidence on stem cells regarding ED is based on animal models of diabetic ED, where there were improvements in functional and structural changes. A limited number of human studies exist investigating the use of stem cells in patients with ED, but overall, the results seem quite promising. Mirzai and his group conducted an RCT comprising 20 patients with diabetes not responding to conventional treatments where autologous mesenchymal stem cells were used. There was a slight but significant increase in IF5 score in the intervention group. However, there was no difference in peak systolic velocities and resistive index of the penile vessels in the different groups. No complications were reported. Another open-label phase 1 clinical trial assessing the safety of bone marrow stem cell treatments for ED in 4 diabetic patients with refractory ED found no adverse effects during the first 12 months of follow-up. Secondarily, there was a significant increase in the IF15 score in comparison to baseline values. However, very low sample hinders probably any valid clinical utility. The efficacy of placental matrix-derived stem cell injection in patients with ED was also reported in different studies. For instance, in 2016 by Levy and his group. Specifically, they injected 1.5 milliliter of placental matrix-derived stem cells into the base of the corpora cavernosum. The results were satisfactory and the patients improved peak systolic velocity measured with penile triplex ultrasound. An improvement in erections appeared 6 weeks post-treatment, and erections were retained for 6 months after PDE5 administration. The re-administration of stem cells was also studied in 2018 by the group of Aldemour, and they confirmed the efficacy, safety, and tolerability of repeated intracavernous autologous bone marrow injections in 4 patients with ED and diabetes. An improvement in the IF score was noted without any side effects from the 2 treatments. Overall, the clinical studies published so far show encouraging results. Improvement of sexual function is reported with no or very minor side effects. Unfortunately, although pioneering, all of these are small studies with a short follow-up period, various etiologies of ED, and often without a control group. The limitation to contemporary data is the lack of RCTs and the small number of existing studies. Today, we can conclude that until more high-level evidence is available, stem cell therapy in ED should be considered experimental and should only be recommended in clinical trials. And that is what the guidelines on both sides of the ocean are highlighting today. Very promising, but too soon to introduce into daily practice. PRP, platelet-rich plasma. Although the use of PRP in urology is still in its infancy, its debut in other fields of medicine, such as orthopedics and plastics, is 1987. There have been studies conducted in these fields discussing its safety and efficacy, but despite more than 30 years of use, its physiological properties and effects remain poorly understood and controversial in the context of autologous injections. A better understanding of this emerging, sometimes controversial modality is essential in guiding physicians, urologists, colleagues dealing with patients suffering from ED or PD. Let's talk about the evidence around the effectiveness and safety profile of autologous PRP injection in men with male sexual dysfunction. Autologous blood is drawn and centrifuged to obtain the platelet-rich plasma fluid with a concentration reaching up to 7 times physiological levels. In order to maximize its therapeutic effect, the product is injected when its concentration is more than 1 million units a milliliter. Tissue restitution occurs through paracrine and autocrine effects of various secreted products. In fact, platelets secrete various chemokines and cytokines, mediating inflammation and various growth factors, stimulating, therefore, an immune response and promoting wound healing. For instance, PF4, one of the secreted growth factors, attract neutrophils and eosinophils. PDGF and TGF-beta stimulate collagen synthesis. IGF-1 promotes growth. VGF and EGF or other growth factors present in PRP, promoting blood vessel formation. We mentioned those earlier regarding shockwave therapy. PRP is thus believed to provide rejuvenation of tissues by stimulating the restoration of blood flow, stabilization of the extracellular matrix through downstream collagenase secretion and collagen synthesis, and tissue regeneration. To maximize growth factors release, some have studied the impact of various activating agents like calcium chloride or thrombin on platelets. The rationale is that platelet activation produces a conformational change, resulting in a cascade of degranulation and then aggregation, thus maximizing the growth then of the growth factors release. Classification system of platelet-rich plasma. Well, actually, there are 3 classification systems. In 2009, Ehrenfest and his group proposed to classify PRP in 4 main groups based on 3 parameters. The technical characteristics, for instance, the preparation kits and centrifugation, the content, only platelets or leukocytes, and the fibrin architecture supporting the cellular contents. Since then, other classification systems have been proposed. In 2012, Mishra et al. Proposed a classification system based on the content of white blood cells, PRP activation status, and platelet concentration. In 2016, Magellan and his group proposed the DEPA classification system. DEPA stands for dose, efficiency, purity, and activation. This is a complete classification system based on quantifying each of the 4 components. However, other authors published and highlighted the need to register the quantification methodology in the CE medical devices preparing the PRP solution. And that cannot be determined by the user. So the DEPA system might be too complicated to use in certain settings. And so, because of its simplicity, we all use the classification proposed in 2009 by Ehrenfest. And that is the one who is mostly accepted and used. But it lacks the characterization of the total volume, the presence of red blood cells, and the concentration of the platelets. Adverse events. In plastic surgery and dermatology literature, no serious adverse effects secondary to PRP were noted when used for the treatment, for instance, of skin conditions. Sometimes hyperpigmentation was mentioned and wound problems. So minor complications like infection at the site of injection or hematoma have been described, but could, of course, be avoided with proper precautions and preparations. Are there any contraindications? Yes, they have been listed as the presence of cancer and metastasis, acute infection or active treatment with antibiotics, severe thrombopenia, severe anemia, use of anticoagulants, but that is more probably of the injection and not due to PRP, and the immediate use after cortisone injection. Of course, for women, pregnancy and breastfeeding is a contraindication. Regarding administration protocols, there is a lot of heterogeneity in the published protocols. And because of lack of data and classification characteristics, it's not always easy to compare those different protocols on efficacy. Furthermore, several centers today are offering elaborate treatment protocols with the use of shockwave, stem cells, PRP, and sometimes even concomitantly. The rationale to perform a treatment that induces inflammation, like shockwave, before PRP, has been used for several decades in plastic and aesthetics. For instance, where microneedling is applied to create an inflammatory response to the area where PRP will be injected. It has been proven that adding microneedling to hairless therapy with PRP, a benefit can be obtained. The same logic, if we could use that word, applies then for shockwave therapy to the corpora cavernosa. A current practice a lot of male wellness centers propose today. I could only find one publication without robust data, but suggesting also an improvement in clinical efficacy by the combination of shockwave and PRP rather than shockwave alone. This brings us to the second part of the webinar, where my esteemed colleague, Dr. Sebastien Beley, will share his knowledge about the use of PRP, especially in erectile dysfunction and Peyronie disease, and share his own experience. I'm happy to answer all of your questions later on during the Q&A.
Great. So can we move to the second video, please? It goes really nice presentation. Okay. Let's go with
Hello everyone, this is Sebastien Beley from France, and I would like to talk to you about male regenerative therapies using PRP. So what PRP means? PRP is platelet-rich plasma. It's used to stimulate tissue healing and regeneration since the end of the past century, after the discovery that it contains growth factor. It's an autologous biological therapy, and it contains supraphysiological concentration of platelets and growth factors derived from vascular endothelial growth factor, platelet growth factor, fibroblast growth factor, transforming growth factor, and other components of the plasma milieu, stimulating growth and repair. It's affecting stem cells recruitment, inflammatory reaction response, angiogenesis, and wound healing. Growth factors are known to interact with cells receptors and instigate signal transduction, which then stimulates cells growth and proliferation. It also activates stem cells, resulting in a new collagen formation and a tissue regeneration. As you can see here, PRP will accelerate the healing process, making all this cascade of events shorter in time. It makes, at the end, a shorter healing time. PRP will mimic the normal healing process that occurs when a tissue is wounded. There is a background leading for the use of PRP in men's health. First of all, regarding erectile dysfunction, urologists are looking for a permanent cure of ED. Neovascularization using vascular growth factor has been recently demonstrated to be feasible in animal models. This is what Siroki and Azozoy said 20 years ago in Journal of Urology. Till then, there has been a strong demand for regenerative therapies. There is also less trust in pharmaceutical industry, leading patients to ask for that kind of regenerative treatment. And then, of course, there is a direct to consumer marketing in USA. It's called the P-shot, and since now 13 years, it has been a provider of injection of PRP to the patient in order to treat erectile dysfunction. Peyronie's disease also is a user case for PRP. Since March 2020, there is a withdrawal of Xiapex in all Europe, leaving all the non-surgical patients without any other option. This includes moderate deviation, hourglass deformity, and so on. So, platelet-rich plasma as a therapy for male sexual dysfunction, is it a myth or reality? This has been published 4 years ago, and it was already asking the question. So what's the goal of ED treatment? It's increasing the quality of rigidity of erection, increasing the ability to maintain the erection, and most of all, it has to be safe. We want to restore the quality of life and the sexual life of our patient and their self-confidence. Let me show you two trials that have been published regarding the treatment of ED with PRP. This first one, issued in JSEX Med in 2021, was about 60 patients. Half of them were given placebo and half of them were given 10 ml of PRP as 2 injections with a 1 month difference. We were evaluating the minimal clinically important difference in the IIEF and regarding the erectile domain of this index. This was evaluated from baseline to 6 months after the final treatment. A statistically significant difference of both the number of participants attaining the MCID and the IIEF score was observed at 1 and 3 months evaluation. What we found is patients receiving PRP were more satisfied with the treatment. There was no adverse event during the same study period. So it appears that this treatment, PRP, is a safe treatment and an effective treatment in the short term for the treatment of mild to moderate ED. Platelet-rich plasma for the treatment of erectile dysfunction, that's another double-blind, placebo-controlled, randomized prospective study published in Journal of Urology in 2023 by Thomas Masterson and colleagues. It was reporting the results in 61 men presenting with mild to moderate erectile dysfunction, randomized to receive either 2 injections of PRP or placebo, 2 injections separated by 1 month. Primary outcome was the percentage of men meeting minimum clinically important difference at 1 month after the second injection. The secondary outcomes were changes in the IIEF at 1, 3, and 6 months. Changes in the penile vascular parameters were also assessed. This team found there was no adverse event first, and they found there was no difference in efficacy between platelet-rich plasma and placebo. As you can see, two RCTs has found different results regarding the same use of PRP trying to treat ED. What can we say about the goal now, the goal of Peyronie's disease treatment? We want to treat deformity, we want to spare the length of our patient, and we want to spare their ability to attain and to maintain erection sufficient for satisfactory sexual intercourse. Most of all, again, as usual in functional urology, we are here to restore quality of sexual life and quality of self-confidence. Regarding the treatment of Peyronie's disease with PRP, there is a first study that was published in 2017. It was issued by Dr. Ronald Virag, and it was evaluating the results of 4 injections of PRP with hyaluronic acid directly injected inside the tunica albuginea under ultrasound guidance. What they found is the angulation and thickening were both significantly improved after 4 sessions and continuously improved with the number of sessions. They also found that young patients achieved better results. That's the way they were doing the injections, directly inside the plaque, just like Xiapex was done later on when Xiapex was issued on the market. That's another study published in Urology International in 2019, and it was evaluating the effect of PRP in a Peyronie's disease rat model. What they did is they took 20 rats and they were randomly divided in 4 groups: sham, Peyronie's disease plus PRP, and PRP alone. The Peyronie's disease plus PRP groups received intratunical injections with 0.1 ml of PRP on day 15 or day 0. 45 days following injections, the rats underwent pathological examination. Tissue were evaluated histologically for fibrosis grade, collagen on smooth muscle ratio, and type 3 on type 1 collagen ratio. What they found is they found significant changes in all 3 groups compared with the sham group. The values in the PRP group and the findings in the Peyronie's disease group are similar. What they found is, as a result of pathological examination, PRP shows Peyronie's disease-like effect on rats. What they conclude is that PRP may be a cheap, easily accessible, and an effective disease model for Peyronie's disease treatment research. What they were saying is that PRP was reproducing the same kind of lesions as Peyronie's disease in their rat model. And now I would like to give you the result of a study that we did with my team about a new protocol injecting PRP on Peyronie's disease patients after percutaneous needle tunneling. And these are the preliminary results. This was published in 2023 in the French Journal of Urology. We evaluated the feasibility, efficacy, and safety of a combined treatment of percutaneous needle tunneling with penile modeling and injection of platelet-rich plasma. 36 patients underwent this approach for PD, and the pre-treatment mean and standard deviation curvature was 57 degrees as a mean, and standard deviation was 20 degrees. After the protocol, the mean curvature degree was 40.8 with a 25-degree standard deviation. The curvature angle improved significantly with a mean improvement difference of 16 degrees with standard deviation of 40 degrees and a mean improvement percentage of 47%. And there were also no significant event. As a conclusion, literature shows a growing interest and encouraging results for PRP use in men's health. Safety is always mentioned, and there was no severe adverse events reported in the articles published so far about PRP. But before PRP is mentioned in the guidelines for treatment of ED and treatment of Peyronie's disease, we will need more preclinical and more clinical data to better understand PRP and the plasma milieu's role. As I said, we need to understand what dose do we need to inject. Is it 10 ml of PRP? Is it 20 ml of PRP now? How many shots do we do? We personally now do 6 injections for Peyronie's disease. Do we need to do more? Do we need to do less? How long do we wait between 2 shots treating ED or PRP? Do we use tourniquet for ED injection? We have now with PRP a new way of treating ED and Peyronie's disease. It has to be, in my opinion, amongst other treatments that we can give to our patient. Only we still need to understand what kind of dose do we need to give them, how many times, how often, what kind of dose. It would be the same if we had a new medication on the market, but without having the information about the dosings and the safety recommendation. And most of all, if we want to achieve the good result, we have to pick the good candidates. For erectile dysfunction, is it the endothelial dysfunction man? Is it the man suffering from fibrosis of the corpora? We know for sure that it's not the patient suffering from neurology diseases, would be central or peripheral neurological disease. For sure, we are not talking about the venous leakage patient, and we are not talking about the major arterial obstructions patients. So most probably, there will be something to do about the patient who have an endothelial dysfunction, the patient who have the cardiovascular risk factors without having a severe disease of the cardiovascular system. Regarding Peyronie's disease, it looks like early stage patients do not benefit that much from injection of PRP, and of course, patient with calcified plaque don't do neither. Most probably, it's a stabilized disease that we need to treat before it becomes calcified. So keep in mind, PRP is here to stay. We have strong data supporting its use for ED treatment and for Peyronie's disease, but we still need more data to understand better which is the best patient as candidate and how to use it in terms of dose and frequency of injections. Thank you very much.
Well, thank you very much, both of you guys. Excellent talks. I think that we have many things to discuss. I think that it is better to focus on PRP as this is the topic for today. Another time we can discuss about stem cells or ways or whatever. Let's start with Sam. You know, for me, it's very attractive, the auto-healing process, Sam. And all these regenerative therapies, we have an extremely extensive experience from dermatologists. Female use that for 30 years now. And whatever we do, they have done many, many times. So I think that the issue of safety of this method has been well established in by other specialities. So let's start, because in every treatment, the first thing that we consider is safety. So Sam, do you believe that it is clear that this procedure is safe?
Yes, I think it's a very safe procedure. As you told, we've been using it for many years in different other specialties, so we know we have data from that, and I've used it myself many times, and I had no or any major complication. I think I had once a skin infection, but you could treat it with a local cream, so it is very safe. Yes.
So okay, so we have a safe treatment that's available. So, but on the other hand, I would say, so who cares? Okay, it's very safe. That's why, and also we get something from the body and you give it back, part of it. So it is not under FDA or a regulatory consideration. But on the other hand, why should I do that? I mean, I'm talking about efficacy, to do things that are not harmful just to do something, because the efficacy is not established. So, I mean, it's crazy. Okay, I can do massage of the penis.
But we also tell them to do massage of the penis, the PRP injection, Dimitris. No. It's true, and of course, that is maybe one of the problems with treatments like PRP, is that there is not a lot of support for big studies, and because we have a lot of, let's say, comments about the data, the big RCT, but you need funding for that, and the funding is not coming because there is not really a huge patent that you can take on somebody's blood. So a lot of us have done their own, like Sebastien, and we have groups that do some research, but to include hundreds of patients is really difficult in many European countries, because when you do some research, you cannot charge anything to the patient, so it starts to become very difficult to have big RCTs to organize it. So time will tell within the next years how this will evolve.
Yeah. So let's make clear to the audience that don't expect multi-center clinical trials as you see with the drugs, because no one is going to invest millions without having a patent. And this is something, it is the same as with the shock waves. So we have to, or it is the same, to give you an example, with all the vasoactive agents that we were using for injections. So we have to produce our own small studies, many studies. What I really like, Sam, is that in a very short period of time, we have some publication on PRP, and comparing to stem cells that is going now for 15 years, but with very, very slow moves and very, very small. I mean, with 15, 20, 25 patients. So we hope to see papers, because this is something easy to do and you don't have ethical concerns. That's your feeling too?
Yes, it is. So it's going much faster with PRP when we compare it to stem cells. And of course, the extensive data we have, like from dermatology and aesthetics, really helps to go forward and enroll patients, because you have to enroll patients that agree to participate. And that's a big difference when you talk about PRP and you compare that with stem cells. They're really a bit scared and they don't want to try all of these kind of things.
Okay, thank you, Sebastien. Let's start with the questions, because the questions are coming. I mean, I'm really happy. Please, please, please write your questions. we are going to answer all your questions and solve as much as we can the questions. So you showed a model on Peronis. So how did you also achieve modeling in the last article you showed us by previous alprostadil injection and in-office modeling? Oh, that's for your paper, I think, Sebastien.
It was done in the operating room. It was a beginning of experience. Actually, they are patients from 2019, and we decided to combine PRP injection and percutaneous needling, like the Spanish team from Salamanca did for Xiapex when they decided to publish their new technique of injection. So what we would do for those patients is that we would inject them under GA, the general anesthesia, to allow us to do some modeling against an EDEX-induced erection. So basically, we would try to break the plaque, then do tunneling of the plaque, and then inject 20 ml. And then after that, day 2, we would ask them to vacuum their penises to try to soften the plaque as much as we can. So I don't do it under GA anymore now. It was a beginning of experience, but I thought it would be useful to publish because, as you can see, it's around 40% of improvement, not 40 degrees, 40%, which is not far from what you can get from Xiapex, from a full series of Xiapex injection. But using autologous, much less expensive, at least in France, to go to the OR and having just one injection. So that was an interesting one, but we don't do it anymore under GA.
So, Sebastien, because people also understand some practical issues. So you have the penis, let's say that we have a 1 centimeter plug and you feel it. You have it in between your fingers. So the tunneling, you'll go and you put the needle, I think, if I remember your paper, 24 gauge needle you use?
Yeah, it's a 23 gauge subcutaneous. It's the orange one.
Okay, so, and you go through the whole plug?
Yeah, you go through the plug until you don't feel any resistance, telling you that you are inside the corpora. And then you go back and you inject while you are inside the thickness of the plaque. You don't want to inject where it is easy to inject. It would be a P-shot. You want to inject inside the thickness of the tunica albuginea. So you have to go through it and then go back, slowly injecting and trying to do hydrodissection. So most probably the result comes from breaking the plaque with the needle, hydrodissecting the plaque by the volume of the PRP, which is much more than Xiapex. Remember, we were dealing with 0.58 ml of Xiapex. Now we have PRP with several ml of product. So we can hydrodissect and then counting on the molecular effect of the PRP itself.
And you did how many mLs?
So that study, it was with 20 ml of blood, which is around 12 ml of PRP.
12 ml, okay, 12 ml of PRP, you will get a tumescence of the penis, yes? So theoretically, that will go everywhere.
Yeah.
With such a volume, yes?
Yeah, yeah, okay. You will float the both corporas.
Okay, this is a very interesting concept. I love it, and because just to recall, guys, to recall the placebo effect in the Xiapex papers.
Yeah.
The placebo effect, in my opinion, I don't have proof of that, of course, is because of the needling. Otherwise, I cannot explain that. So let's go with the question. Okay. Why I understand, but please answer to Mikola, who asked, what is the percutaneous tunneling and how it differs from the injection in the plug? I think that you answered now that you go through the whole plug. With injection, you go to some spots, correctly?
Yep.
Okay. PRP contains TGF-beta. Wouldn't this cause more fibrosis in Peyronie's disease?
Yeah, so that was the concern before we started. As you saw, I showed you a study showing us that in a rat model, injection of PRP was doing the same result pathologically as PD itself. But we didn't see that in humans. So, and we have the proof of the daily evidence showing us that either your patient will not be cured from Peyronie's disease, or they will not get better. Either they will get better, but they don't get worse. This is what I've been seen so far by all the teams who did these PRP injections trials. So no fear from making it worse.
And here, let's add to this question that it's not correct that TGF-beta produces fibrosis. TGF-beta is a growth factor that really is released every time we have a wound healing, for a wound healing process. And if the stimulation or the wound is too big, then it goes to a deregulation, autoinduction, TGF-beta, and that is the pathway to fibrosis. So TGF-beta per se, it's very, very unique and very, very useful for the wound healing. So if it's going to autoinduction, that's a pathological state. So let's differentiate this. Let's go, I think this is for Sam, the next. Stem cell therapy has positive results in ED. What is your opinion using exosome instead of stem cells? Oh, this is very new and very hot. Sam?
Yeah. I'm not doing it, but I'm reading a lot about it, but I'm not convinced myself for the moment. But it's a very fast developing area. Have you done it, Dimitris, for the stem cells? No, me neither. So it's a bit too early.
So, and also another question, do you know if there are stem cells studies with good results on Peyronie's disease?
Not that I know.
No, you know. There are some models, but anyway, not really. Sebastien, a question by Mark. Sebastien, what do you recommend for the IPP? Simple PRP or cellular matrix, and why?
For the Peyronie's disease?
Yes.
So, as you have seen, one of the first papers written about Peyronie's disease and PRP was written by Ronald Virag, and he was using PRP plus hyaluronic acid. So I did it myself also. I started on a limited number of patients because the access to the mix of PRP and hyaluronic acid is a problem also. It's a little more pricey, but still I did it. The idea in my mind was if I inject hyaluronic acid on top of my PRP, it's going to bring more volume inside the plaque, trying to break it again from the inside when you try to hydrodissect by injecting under pressure in your plaque. But I didn't see that much difference between this and a well-prepared PRP solution.
I see. Well, yes. else? I think we have covered most of the questions. I want your opinion. My feeling is that we have some data, not enough. It is, what I would like to say is that reading RCT studies in the literature, we have to be very careful. Don't read only the abstract. Go through the paper, check the methodology. Let me give you an example. In our study, the PRP study, as well as in all the studies that we have done with shock waves, through the typical process, okay, of examining patients with erectile dysfunction, we feel that they are organic. And after 1 hour sexological consultation, 30%, 1 out of 3, they are out. Because we did not recognize important sexological issues. So I think in most of the papers, most studies, they don't do that. We do that because I don't want to treat psychogenic ED patients. I want to have clear. In Peyronie's disease, it's very nice that you have the plaque. So you know what it is. On erectile dysfunction, it's not a problem. And now look at this paper that didn't find any difference with PRP, the J-Urol last month. There are some pitfalls in this paper. Number one, okay, they selected their patients, they did vascular testing before and after the treatment. And if you read the numbers, before treatment, all the vascular parameters were normal. So in this group of patients, at least no one had vasculogenic ED. So what was this group of patients? Number two, okay, these patients were using PDE5 inhibitors, and they allowed them to use any PDE5 inhibitor they wanted to. So that means daily, on demand, or combination of daily on demand, whatever, everyone. But this will cover the results. You cannot get result from that. So with these two small things, you cannot really get any value from this data really to help you. I mean, that's the problem. We have to be very careful conducting, because it's very difficult, very hard, many hours, nobody pays you for that, to do RCTs in all these products. So we have to be very, very careful. But you know, typically what we like is to read the abstract, and if I like the method, okay, this paper is good, it has positive results, I will use it. This is negative, I will say it to a talk in order to say this is bullshit. So we have to be very careful and very scientific on what we read and what we share with our audience, because the job of societies like ESSM is to clear and to see to make the difference between the other societies that has not this scientific standard. Two new questions. Is there a difference in using PRP alone or PRP and hyaluronic acid?
Again, for me, I don't know if you have this experience, Sam, but
I have no experience.
And Dimitris neither. So the thing is, with in the tubes where you get hyaluronic acid on top of PRP, you have a little less volume of PRP.
Sorry, Sebastien, because the next one also deals with the same. I have one more question for Sebastien. Sorry, hyaluronic acid forms a matrix around the thrombocytes. Doesn't it make sense to use cellular matrix to have a longer effect on the plaque? So both questions.
Okay, so again, as we all understand here, we are talking about a new kind of treating patients. So we don't clearly understand all the pitfalls and the advantages. As as I could assume, if you are using a hyaluronic acid, it acts like a net around your thrombocytes, like a net around your fishes, around your fish. And you in that way with your net, you could say, I will keep my PRP longer where I put it at the beginning. So I think it's something we need to test on the larger group of patients, because I'm sure there is something to find about this association of both hyaluronic acid and PRP. But to me, so far, as something that I would have published, there's no major difference. But as we said, we are still trying to find the good dose, the good rhythm of injection, and so what we don't see, what we cannot see yet, what we haven't seen yet, doesn't mean it doesn't exist. I think we need all of us, all who are here tonight with us, who are seeing patients. We need to work together to understand better what we are doing. So yes, I think it's promising, but still, I think we need to understand better what we are doing.
Sure. There is another question about insurance, if there is a coverage for shockwaves for this therapy. I don't think so, and this has to do with each country. There are different things by country, so we cannot discuss. So, guys, so I like what you do. I will start tomorrow. I will get one old centrifuge from the biochemistry lab. I have a friend there. I will prepare PRP, and why not, because it's easy to produce it, I will do 30 or 40 ml in order to improve efficacy, and I will inject to all my patients. Do you agree, Sam, with my practice?
Thank you for this very easy question. No, we need to remind that we want at least a platelet concentration of 1 million units per liter. And then, if we can, we want to have a high purity. Purity is the percentage of cells in the plasma compared to the red blood cells and the white blood cells. So a high purity without a high concentration, let's say it's useless and may be harmful. So the purity is an issue, the platelet concentration, and yes, all the devices are not the same, and you need to be aware of that. Also, the tubing that you use with a filter or not, with hyaluronic acid present or not. So, and then of course you have the whole discussion about activation of the platelet. Are you going to add calcium or not? So that's all things that you need to inform before starting. Yes, you cannot start like that.
One last question and then closing remarks. Regarding the tourniquet, I think that we have to use that. And what I personally suggest you as an idea, if you have a shockwave machine, do a shockwave, perform a session, and then inject. Why? Let me explain to you. You produce a microtrauma, that's how it works in shockwaves. So when you inject right after the end of the session, the PRP goes directly to the microtrauma areas, to the sites. So it binds there. So I think it is a best way with a tourniquet and with a shockwave session before the PRP to keep it there, to keep it in the site that you want. So closing remarks by the president, the former, the present president, close friends. What I would like to ask you, and Mr. President, I want one more of these webinars on PRP, but on a different way. Please say that to our chair of the educational committee, to be practical, to go to explain what it is PRP, what is the centrifuge, what are the difference between FDA approved and non-FDA approved, why there is a limit of 7,000, you know, that some said, and not go to 20. Why we have to do calibration with the patient blood, you know, to give some directions on the current knowledge of the production and the procedure, the tips and tricks. So this is as proposal. I think Sebastien and Sam would support me asking for that. We have so many experts on ESSM. Thank you from my part. Giovanni, can you close, please, the webinar?
Yeah, I really thank you, all of you. Dimitris, you are fantastic as a chair, as always. And also Sam and Sebastien, thank you for your help. I think you addressed all the conflicting issue regarding these topics. For sure, this is the first collaboration that we have a sponsor. I really thank again RegionLab, and I really appreciate your idea, Dimitris. So for sure we can discuss it in Bari, but also in a future webinar. Carlo, if you can say some words, and again, thank you to everybody, a great success, people around all the world, a lot of discussion, so fantastic webinar. Carlo.
Just thank you so much to all of the participants, and I mean, Sebastien and Sam were good, but Dimitri is always, you know, on the top of everybody. So congratulations to all of you guys, and I hope to see all of you, no one excluded, in Bari, and hopefully very soon. Thank you so much.
Bye, thank you.
Thank you.
Hi, Michael.